अच्छा पीपीटी स्टार्ट कर दे हाउ विल कौन सीवी स्टार्ट फर्स्ट सीवी बेका ठीक है ओके
A very good morning to everyone. I'm Dr. Samyukta, consultant psychiatrist of INK. On behalf of this institute and psychiatry department of Institute of Neuroscience, Kolkata, I welcome all of you for today's CME on internet addiction. There's a little change in program, please bear with us. So we will be starting off right now with the scientific sessions. The first session will be treatment considerations in internet and video game addiction. I invite Dr. Devashish Konar and Professor Dr. Uday Chowdhury to chair the session. And I also invite Dr. Vivek Benegal, the speaker of the current topic. Dr. Devashish Konar, he works as a consultant psychiatrist and director of Mental Health Care Center, Vardhaman and Kolkata. His interest areas are child and adolescent psychopharmacology and public mental health. He is currently the president of Indian Association of Child and Adolescent Mental Health and president-elect of Indian Psychiatric Society West Bengal branch. Currently, he is a sustainability champion of Royal College of Psychiatry, London. Welcome, sir. And we have Professor Dr. Uday Chowdhury. He is a consultant, senior psychiatrist at RK Mission Seva Parishitan Hospital. He is a professor at Vivekananda Institute of Medical Sciences, Kolkata. And also he is an advisor of mental health literacy at Bellevue Clinic. Welcome for today's CME, sir. I now request Dr. Uday Chowdhury to introduce us to the speaker, Dr. Vivek Benegal.
As I am having a very bad throat, Dr. Konar will do the honors for me.
Yes, sir.
Thank you. It's my pleasure to introduce Dr. Vivek Benegal, who is a personal friend, and I know him from student days. He is professor of psychiatry, Center of Addiction Medicine, National Institute of Mental Health and Neurosciences, NIMHANS. Dr. Vivek Benegal works in addiction medicine and the genetics of psychiatric disorders. He is interested in developmental behavior, especially drug abuse and high-risk behavior in street and working children. He is also interested in child development issues and use of developmentally appropriate aids for children's education and recreation. He conducts drug abuse awareness programs and life skill training for children in schools and colleges. He has developed drug awareness module in comic book form. He is involved in epidemiological assessment of and intervention of drug use in high-risk sexual behavior among street and working children. He has diploma in communication in film and theater. He has experience in theater and documentary cinema. He has made the film and educational side shows. He is interested in theater and cinema for children. He says that that is his future preoccupation, that he will like to devote more time after his retirement to all these fields. Anyway, he's a charismatic personality. I have heard him many times and I have watched him evolving from a junior level teacher to a very senior orator, and I always look forward to listening to him. It's my pleasure to be in this seminar. And I thank INK for providing me with this opportunity. Thank you so much.
So please come on to that. Yes, sir.
Right. Vivek,
The session
I
is
think
on.
you start the
live.
session.
Yes, sir. The session is live on YouTube and INK website. Thank you.
Thank you for highlighting the last part. Actually, for
I'm losing my marbles, so I can actually, walk all over the place, and all of you will pardon me. So, let me start off by. Can I have the pointer, please? Let me start off by, statutory disclaimer. One is that I honestly tried to go through the latest systemic reviews and meta-analysis of treatment for internet gaming. There's not much joy there. Most of them actually say that not much is known, and a lot more RCTs have to be done. So I have actually taken the opportunity of that word, considerations, treatment considerations, and I will try to focus on a general approach, which is not necessarily an approach to only internet gaming, but a general approach to all addictions. Because by now, it is pretty evident that when we talk of whether it is substance addiction or whether it is behavioral addictions, there is a lot in common. I mean, starting with a shared or common neurobiology, starting with common risk factors, starting with neurodevelopmental origins, etc., etc. This is creaking. It should come down. So I don't think you can see it if I stand there. Okay, so let's talk a little bit about what is our current approach to the treatment of addiction. In fact, not just addiction, but all psychiatric disorders. We, at least our generation, hopefully, that's not happening in the younger generation. Our generation has been trained to treat the diagnosis. That is the tip of the iceberg. And therefore, when you look at addiction, our focus has been on banning the bottle, or prevent use, or in the larger context of psychiatric disorders, treat the delusion, hallucination, control the depression. And the way we do it is we think that there are magic bullets, because we live in a pharmacocentric universe. Everybody will be talking. You go to any conference, people will be going blah 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 about dopamine this and serotonin that and this network and that. The truth is that there is very little known about it. I mean, for example, if you look at this whole dopaminergic theory of schizophrenia, as you are aware that there is much recent literature to doubt whether there is a dopaminergic theory to schizophrenia. Ditto for depression. So what it does do, this particular approach of just treating the tip, is that it creates a revolving door phenomenon. People come, we treat them, they get better, go out, come back again. And this leads to continuing poor quality of life. You can treat a person with schizophrenia and get rid of the person's delusions and hallucinations, but that doesn't mean that you improve quality of life. You can treat a person with addiction, put a person in for the favorite treatment that we have of a rehab center, and the person comes out and goes back to the bar. This is the bane of our profession. It gives rise to two things. One is it gives rise to stigma, and on the other hand, it gives rise to therapeutic nihilism. In fact, one of the favorite treatments of psychiatrists when faced with a person who comes with a diagnosis of either borderline personality, so-called, or addiction, or ASPD, is refer the patient to somewhere else. And so, why am I talking about this? Partly, it is a problem of our current diagnostic system, our classificatory system, our way of understanding the illness. And there are some assumptions that we have, which we have been taught. I hope the younger people in this audience will lose those assumptions and will make newer mistakes. One is that our diagnostic system is categorical, that you either have a disorder or you don't have a disorder. And so you are treating a diagnosis. You're treating schizophrenia. If the person has schizophrenia with other problems, who cares? I have to treat schizophrenia. The other thing is, and of course, this does not allow you to treat the different variations that actually occur in the natural world. The second thing is that our diagnostic system is polythetic, based on a number of criteria which have to be fulfilled, ticked, before you can make the diagnosis. So you have 5 out of 9 criteria. You can have, if you have 9 criteria, you have about 150 presentations of that illness. Just do the probability matrix. So this helps us ignore subthreshold presentations, and doesn't matter whether, I have students saying, sir, this person does not fit criteria for ADHD, should we treat? Is the person got distress? Yes. Do the parents have distress? Yes. Then treat. You treat distress, not a diagnosis. The fourth thing is, we diagnose by exclusion. We are taught that this is schizophrenia if it is not bipolar disorder. This is so if it is not that. In real life, that's not the way diseases happen. If you have one psychiatric disorder, the chances that you have another psychiatric disorder is almost 70%. This is not me making it up. This is data from the Dunedin trial, Dunedin longitudinal study in New Zealand. If you have 2 psychiatric disorders, the chances that you have a third psychiatric disorder is 40%, and so on and so forth. And none of us, believe me, none of us actually look at those possibilities. Once, we as students are taught, once you made a diagnosis, go at it. I'm probably being a little harsh here, but I'm just trying to make it slightly more, what do I say, black and white, so that I am able to make my point. The other thing that we believe in is that diseases occur de novo. That the day you are able to make the 5 out of 9 diagnoses is when the illness started. And so, again, we are taught, when was the first time that you had these symptoms? When was the time before that you had no symptoms? And the favorite thing that at least my students say, sir, he was perfectly okay before this. His premorbid personality was perfect. It does not happen. It cannot happen. Because most psychiatric disorders, like cardiac disorders, like hypertension, follow this thing where there is a homotypic or a heterotypic continuity. That there are symptoms which are there from childhood, and the same kind of symptoms, manifest itself in greater and greater proportions as the person goes along in life. Or heterotypic, you have some symptoms and you get different symptoms. We are no longer in the place where we believe that a person who has developed schizophrenia will only remain with schizophrenia. You have, throughout the lifetime, you have different presentations. The fifth thing that we are taught is to be atheoretical. It is a good thing because we don't know much about it. But there is a theory developing, and especially for the younger people in this room, I demand that you learn the theory. I demand that you understand the etiologies that are there, because there's enough to start working with. For example, one of the things that we are learning, and this is work that we have been doing for the last 10 years, we've been creating normative curves of brain development, brain structure, brain function. And these are, this is Isha Sharma, who has done this work. These are the normative curves of cognitive development in Indian children. And what we see is children who develop these cognitions in the lower centiles have a larger or greater risk of developing problems, psychiatric problems, depression, anxiety, ADHD, etc. Similarly, we have also worked together to create brain charts for human beings from 0 to 100. Now, this was done using volumetric data from 1.5 million brain scans, MRI scans, where we actually mapped every part of the human brain, and we have maps of the normative growth of it. So this allows us to actually predict that deviations, look at deviations, and develop predictive models. We can't predict them yet, sorry. Develop predictive models as to what happens when there is a deviation. For example, this is a thing of normal brain age, which we are now using. This is a machine learning based index, which we've derived from cortical features to predict deviation in brain development, which is able to predict at around, it predicts your chronological age at plus minus 3 months, and deviations on this are associated with psychopathology. For example, you see the deviations from the red line, and the deviations, for example, anxiety, externalizing disorders, psychotic disorders are associated with these deviations. So why am I talking to you about these? Because what we are understanding is that psychopathology is not a black and white thing. Psychopathology is actually a continuous deviation from the normal. In the same way, the hypertension, somebody who's hypertensive is not a giraffe to somebody else's, a normotensive zebra. Our classificatory system actually taught us to do that. That if you have schizophrenia, you're different from normals. Whereas we are now seeing that a lot of brain networks are coming into play. And I'm just showing you some of these things to tell you, to build some understanding of what I'm talking about. So there seems to be certain brain networks which underlie certain functions. We are still not there yet. We're trying to do that. This is some work from our ADBS cohort, where we looked at brain networks across 5 psychiatric disorders: schizophrenia, bipolar, OCD, addiction, and dementia. And what we found was that people who had any psychiatric disorder had a particular signature, which was transdiagnostic across all psychiatric disorders. And we also had disease-specific signatures, but there are certain things which give rise to the risk of developing psychiatric disorder, which is called the factor P. Your risk of having any psychiatric disorder. So this again, for example, is data from a CVEDA cohort, where we are able to look at the brain networks which participate in, say, ADHD. When you look at the brain networks, you find that a large number of networks are associated in the signature for ADHD. For example, there are visual networks. There are, of course, the default mode network, the CEN, the central executive network, the salience network, and various other networks. What happens is that there is a deviation in these networks to a certain degree. So there is a quantitative variation, there's a continuous variation in these things, as opposed to the categorical model that we looked at. Now, I'm talking about this because this really turns me on. If it doesn't turn you on, raise your hand, say, go on, get on to the next point. The other point I wish to make is that mental illnesses do not arise de novo. What I talked about was the fact that mental illnesses are a result of changes which occur in psychological functions. Everybody has psychological functions. Everybody has cognitive control. Everybody has emotional control. Some people have a little less, some people have a little more. And if you put all these Lego blocks together, you will get ostrich, or you get a tractor. Have I confused you? No. Okay. The second one is that mental illnesses do not arise de novo. That long before the first SIP, or long before, in our case, we're talking about internet, these are children who start developing problems. And usually they are related to conduct, they're related to behavioral problems, which are seen and they're the mother's report. So this brings us to this large overarching theory, which was discussed in the 1960s by a gentleman called Barker, Dr. Barker, who talks of the developmental origins of health and disease. This is currently my current concern, so I bring it up everywhere. But basically, Barker is talking about the fact that certain things happen during fetal life, and that is the first hit. That changes the trajectory of your brain development, and that changes your psychological abilities, which you use day in and day out to engage with or interface with the world. It changes the way you are able to deal with stress, it changes the way you're able to deal, etc., etc. And then later on, you have a second hit, which is again an environmental hit. It could be loss, it could be adversity, or it could be violence, whatever. And because your psychological abilities are impaired, you decompensate and you start developing problems. And the kind of problems you develop are quantitative changes from your normal abilities. After all, what is a delusion? A delusion is the fact that I give more emotional valence, emotional value to the fact that Devashish is looking at me like this. And why should he be looking at me? There seems to be some reason why he's looking at me like this. And if my psychological abilities are such that I find threat in every emotion I see, oh my God. Okay, so time over. Okay. So this is the whole thing, that psychiatric disease seems to be an outcome of things that occur across the lifetime. And more we are realizing that psychiatric diseases, whether it's schizophrenia, whether it's bipolar disorder, whether it's addiction, are diseases of the neurodevelopmental continuum. For example, addiction. What happens to addiction? I mean, one of the things that we are taught is that if you use something over and over and over and over again, the brain learns. That's how we learned our 5 times tables. If you use a substance over and over and over and over again, the brain learns. No big deal. But there are some people where the learning is a little bit more. There are some people who start earlier because they are more impulsive, and they start using toxic substances when the brain is less myelinated or less protected, and therefore the learning is much more heightened, and therefore the habits and the learning is much more prolonged and much more difficult to get rid of. So, of course, once the learning occurs, It occurs by changes that occur, epigenetic changes that occur, which actually changes the expression of the genes, and these are long-lasting, and therefore these are fairly long-lasting behaviors. So our favorite way of dealing with, say, addiction, of taking a person and putting the person in a rehab center and hoping that the person will forget, whatever the guy is doing, is slightly ridiculous, to say the least, because genes don't alter that fast. So basically, our understanding of addiction, if I have not confused you beyond belief, let's come back to addiction again, is that people have vulnerability, and the common vulnerability which seems to be underlying, wow, it's nice. Can you see this thing? The common vulnerabilities which seem to be underlying not just the vulnerability to addictive disorders, but to almost all psychiatric disorders, is a combination of cognitive control, poor cognitive control, the inability to sustain motivation. We keep saying ADHD. People with ADHD have no problems with attention. They have problems sustaining attention. Give them a phone, they can stay attended for 20 hours. You have problems with delaying gratification because you have a reward circuit problem where you do not get the same kind of rewards that other people do from your natural rewards. So you have a reward deficit state. You have a problem with impulsivity, which is why you go and experiment with things much earlier than you're supposed to. You have a problem with emotional recognition, empathy, theory of mind, which we call, what is it called? Cold, aloof temperament. These are people, if you give them emotional faces, this for all the psychologists here, you have this test of, what's the guy's name? I forgot. The non-barrel coin. Anyway, even if you do that, so if you give these kids these emotional faces, they only see threat. Even neutral faces, they see threat, and that's how they behave in life. You say things to them, and they get rejected. Rejection-sensitive dysphoria is the badge of all our tribe. So you face real or imagined rejection, and you either break the TV or slash your wrist. Right? And again, this is something which is trans-diagnostic. And the other one is, of course, emotional control. Difficulty in controlling your moods. You have quicksilver moods. So what happens to these children? These children find that they have increased reinforcement with things that increase dopamine in the reward circuit. It could be coffee, tea, cocaine, heroin, or it could be something which gives you a jolt every time you watch it. Same thing. And when you do that, I mean, it's very simple. A person who doesn't have this difficulty is given alcohol and goes, wow. A person who has a reward deficit, given alcohol, says, wow. But he's not getting wow from work, not getting wow from other natural rewards. So this is the wow which says, let's do it again, over and over again. I mean, the favorite example that I have is that if you give me a bottle of water here, I say, okay, fine, thank you. You give me the same bottle of water in the Thar desert, I say, wow, give me some more. Okay, and so these are kids who are more likely to repeat these experiences, whether it is with substance of abuse or with instruments of abuse, and do it repeatedly. And because these are young people, most of the time, whose brains are still unmyelinated, whose brains are still unprotected, remember those experiments that you did in school with copper wire? You put sulfuric acid in it, you got copper sulfate. The same wire, if you use those myelinated, insulated wiring, put sulfuric acid, nothing happens. Same thing with human brain. Young ones have less myelination, are more likely to have, greater neuroadaptation. Older ones, at the age of 35, if I start drinking, my risk of developing addiction is 5%, not 0, which is the same as the general population. Start drinking or start seeing iPad at age 3, the chances, which is what everybody is doing. Don't make a face. All of us are putting our children with an iPad and, from age 3. Then the chances of developing problems are almost 85%. So this makes it likely that there will be early repeated use, leading to neuroadaptation, which I already talked about, giving rise to certain consequences. So this is the basis of addictive disorders, that you have a predisposition to early repeated use because of your psychological abilities and underlying, functional brain networks, and repeated use leads to neuroadaptation, and both have consequences. So when you get a person with addiction, you have consequences of the vulnerability which is there across lifetime, and you have consequences of neuroadaptation due to repeated exposures, which is happened, now. And you have consequences. Consequences are in, for example, loss of control of the substance, salience, withdrawal, craving, relapse, which we call dependence or addiction. Consequences could be, substance-specific medical consequences, which you don't get too much in, in this co-occurring medical problems, psychosocial problems secondary to the dependence, and lifelong problems secondary to the vulnerability. So when you're planning treatment, we actually train our students to plan treatment based on this. So you have a triangle to remember. There's vulnerability, there is neuroadaptation, and there are consequences of both. And if you have to plan treatment for all 3 nodes, otherwise what you get is a revolving door phenomenon. Okay, so come back to the literature on IGD. You find that some of the things that I talked about are again common to, not just IGD, but to all substance use disorders, males, younger age, people with ADHD, OCD. Now, one of the things that we have learned, when I started out my career, it was externalizing disorders that we kept talking about. That it's externalizing disorders, ADHD, ODD, CD, ASPD are the ones which are the major vulnerability factors for addiction. And that is because of the work of people like Mark Shakir, Bob Troninger, and all these people. Through the last 30 years, we realized that it's not really the externalizing disorders alone. It's the externalizing and the internalizing. And the common factors are cognitive control, emotional discontrol, emotional regulation. And that is shared by, across the board, which is why people with schizophrenia have a very high risk of addiction. Bipolar, very high risk of addiction. People with EUPD have very high risk of addiction. People with ADHD, name it, everybody has a high risk of addiction. And so you have other behavioral factors, personality traits. I'm not going into all these things. But 2 things, starting early is a problem, and having some of these vulnerabilities is a problem. So this is what I've been saying. So externalizing temperaments and ADHD is the most common thing that is associated with risk. However, what we are seeing, and I kept this slide here because it's not well represented in the literature, but this is something you see in the clinic. A lot of the kids who come in with internet gaming disorders and all the other behavioral disorders, there are a lot of kids with ASD, autism spectrum, broad autism spectrum criteria, OCD, and this is a fight that Janardhan and I keep having, whether we should classify it as OCD or So the relationship between interpersonal trauma exposure and addictive behavior. And this is again something which is now being reflected in the literature. And if you go back, you find that there is a huge impact of adverse childhood experiences. And adverse childhood experience, we have a paper recently which we showed that adverse childhood experiences was one of the best predictive factors for later psychiatric disorder. In fact, we have a paper now coming out where we generally looked at the resting state data, and we were able to, using this AI models, to separate the resting state data and look at things which were coherent and things which are not coherent. And we went back to look at the children whose brain networks were not coherent, and we found that the major thing that told the two apart was childhood adversity. So the signature of childhood adversity on the brain is very, very major, and it continues across life. Okay, so these are negative outcomes. Hopefully you're going to talk about some of this, so I will not. How much time do I have? Okay, so I have to finish in 5 minutes. Okay, that is the wrong thing to tell me. Okay, as if that's any better, but anyway. So this is again, data from a student of mine who did this as part of her thesis, and where we found that internet addiction rates were much higher in those with earlier onset of use and psychological or temperamental difficulties. Okay, I've gone over this, so I'm not going to go into this in greater detail. Behavioral, I started with this saying behavioral addictions resemble substance addictions. Who will develop a problem? No prizes for guessing. Younger you start, the greater the problem, greater the access, more of the vulnerable you reach, greater the problem. Adversity, stress, and access to other substances increases risk. Persons with difficulties in cognitive control, etc., which I've already talked about. So let's come back to what I have been asked to speak on, which is treatment. So what are the core elements to address in a treatment plan? I already talked about the fact that you deal with neuroadaptation, vulnerability, and cumulative consequences. This is a slide taken from another presentation, which is why I've talked of liver, lover, livelihood law, which is something which is more relevant to substance addictions. But you get the gist. What does the literature say as far as interventions for gaming disorders, etc.? I mean, I looked at two of the most recent ones. This is a meta-analysis and systemic review, which came out 2 months ago by Chen and others. This is obviously a Chinese group, but most of the work is being done in China and Korea anyway, which look at the fact that there are certain things which are common across most of the interventions which are being done. So there are behavioral therapy, there is psychotherapy, there's electrotherapy, which basically focuses more on RTMS and a few on PDCS, and there's pharmacotherapy. So these are the broad headings, and the jury is out on which really works. At the end, like all Cochrane reviews, this one also says, this is not a Cochrane review, saying that if you combine all of them, you get a better outcome than if you use one of them. It's the law of 1/3 in psychiatry, that we always follow. Similarly, so these are some of the things which have been tried. I mean, this is in slightly bolder letter that you see. Behavioral therapy consists of, arts therapy, other things, electrotherapy, pharmacotherapy, and psychotherapy. So these are some of the interventions which have been used. As far as pharmacotherapy is concerned, atomoxetine, bupropion, and MPH have the greatest data on them. But it's obvious what people are doing. People are not treating the addiction itself. People are treating the baseline for the addiction, the risk factor for the addiction, because there's so much ADHD, MPH, atmoxetine, etc. So therefore, you can see that pharmacological treatment has mostly dealt with these. There's some work which has been done on the use of the so-called anti-craving agents. I call it so-called because no anti-craving agent actually reduces craving. It's a lie. What anti-craving agents basically do is prevent greater use, prevent lapse from being a relapse, if at all. Nothing decreases craving. So none of these things actually work, whether it's for substance addiction or for here, to reduce craving. So none of it works unless your patient actually goes back and has a drink on top of the alcohol, on top of the naltrexone. And this is not what we do not tell our relatives and patients. We say, oh, it's going to reduce craving. And when the guy goes and drinks, the relatives come and try to beat us up because you promised them a rose garden. So we need to be aware of what we are selling. We need to sell, but please be aware of what you're selling. Okay, so Chen's review says that the effective intervention for gaming disorder identified that 4 interventions are effective for gaming disorders: group counseling, craving behavioral intervention, acceptance and cognitive restructuring intervention program, and short-term CBT. And of course, the underlying thing is that results showed that studies had a medium to high risk in randomization process and a medium to high risk of overall bias, which means you don't know what's happening. There are other things which are coming up, which are internet-based and mobile-based platforms, virtual reality therapies, ecological momentary assessment. I'm not going into details because these are very, very new. The other thing that I thought we should talk about is that we need to be able to know how much is too much. When we talk to our parents, when we talk to children, when we go to schools, how much is too much? And these screen time guidelines are internationally accepted. The IPS, Indian Psychiatric Society, has come out with international guidelines. The Indian Association of Pediatrics has come up with guidelines about normal use, or use which is because you have to use. You can't get away by not using a cell phone. So some of these guidelines are there. I'm not going into details, but I think the slides are self-explanatory because the graphics are fairly big. So there are tips for teens which can be used. Screen time guidelines for older people as well. Huh? And this is good data to have because this is something that we should actually be telling our. This is yours, no? Isn't this poster yours? Tirani? Anyway. So again, these are certain. I'm going rapidly through this. If you want me, I can talk about it. But I thought that Okay, sorry. Let's end with treatment philosophies. And so, one of the things that needs to be done, it needs to be done as treatment. We are at the end of the day healers, and the brain at the end of the day is a sense-making organ. So your first job is to help the brain make sense of its current predicament, its current state, its current distress, etc. And when most people come, they come to you, they come because they are in a stuck state. They're asking the same questions and getting the same answers. And your job as a healer is to reframe that in a different context. Reframe that so that they can say, oh, there's something else that can be done. And yeah. So reframing is a major part of engagement with the child and with the parents, that you reframe this in a different context. Usually our first clinical thing is কতটা খাচ্ছ or কতটা use করছো. You're perpetuating the myth. You're saying you're an addict, and the first response is I am not an addict. ওরা যা বলছি ওটা ঠিক নয়, right? And so the first thing that you do is you're at loggerheads, you're in conflict. And so one of the things that we train our students to do is to not talk about it at all. Usually in our addiction clinics, we do not talk about addiction, at least in the first go. We talk about other things. We talk about abilities. So for example, I would use about half an hour to 45 minutes. I have that time because I'm an old person. I take time to sit and talk about the abilities, basically about cognitive control, emotional control, etc., etc., and say, have these been affecting your life? Yes. Want to do something about it? Yes. Okay, but you'll have to do something about that. Okay, I'll do that. So reframing is a very important first step. You reframe, you make contact, the patient is yours for life. People will get angry with you and go off and come back. World is a circle, but they'll come back. The second thing is plugging vulnerabilities. I believe that is the crucial thing, because that is the core. That is the core of the problem, and you need to be able to plug those vulnerabilities, whether you do it through pharmacological means or non-pharmacological means. The next one is support. Remember, a lot of the people who have developed problems do not have support, and that is part of the problem. That has created the problem. That is part of the childhood adversity. That is part of the whether it is their ADHD or their UPD, which has got them to lose support, but they do not have support. And sometimes you require reliable adult mentoring. And just before this process started, Uday Chaudhary and I were having this discussion that sometimes this is the most important thing. But even a person with very severe, Uday was telling me the story about a person with very severe schizophrenia, with delusions, hallucinations, and all he had to do was sit with the person and put the delusions and hallucinations in perspective. And that is a very, very interesting theory that is, not theory, a method of treating bipolar disorder that is coming into practice, of putting things into perspective, using narrative, therapy, using all the other therapies. Breaking habit chains is very important. Restructuring your ADL, restructuring your, how you do things. Preventing lapse, because lapse will happen. Accept it, get the family to accept it. There is no magic bullet, there is no magic treatment. Lapse will happen. Let's be prepared for the lapse, and deal with relapse prevention as a very major part of the treatment. Whether you use treatment for craving, using pharmacological treatments, relapse prevention therapies, other support. And let me end with the one thing that I have found the most satisfaction with. It's, when I draw things for my children, there's one section where I draw one mountain with snow on it, and I call it, go find your own Mount Everest to climb. And not often, I will say 99% of the time, this is the one thing that gives, my client and me the greatest joy. Because in the last 30 years of my life, that is the greatest joy I've had, working with people who find their Mount Everest and, give us glimpses of many. I'll end there. Thank you. Sorry, I was all over the place. If there is time, I'll take your questions, or I'll do it outside. Oh, sorry.
I think all of you must agree that it was really a masterclass. And we are going through just not psychiatry, which is taught in our institutes, in our graduation and in our post-graduation days. Now you have seen the essence of mental health care with his talk. And this is very, very important in today's context, where we are focusing too much on algorithms and we are having a lot of passive learning. We have forgotten to go to the bedside clinics and listen to the patients. So now this type of talk will give you an insight about the essence of the subject, psychiatry. And one more thing I would like to tell you, we are discussing before that. When a patient comes to you, he's having some problem. If you think, oh, he's a drug addict coming to me, then you are losing the track. If you think that one person, he's suffering, and I'm another person, I'm trying to help him, try to understand him with empathy, with genuine concern, and then only you'll be able to help him. So what is important, not only just having a pathology deficit mindset, what we need is a resilience-based mindset. And that will help to the road to recovery. And I think many of you, we don't have much time, you may have some questions. And I invite one question or two questions. Yes, Joy, please.
How would you choose? Because I often struggle about.
The answer is that if you go by the data, self-validate trumps most of the atomic have with a caveat. This is a meta-analysis we did ourselves, so I have to talk about it. We found that atomoxetine seems to be better in people who have a motivational problem of healing, as opposed to the really impulsive one. What would I give you a need? Probably with that.
Okay, I will remember the answer now. So, and also these guidelines, do you think really, because I'm very skeptical about the.
So we can take few more questions.
I just would appreciate if you could tell us few things, maybe guidelines with how we could actually convince parents to not make the exposure to the child as early as it is happening, because we know we can't do without it, and we are sitting with parents who are willing to give the phone at the age of 1, 6 months, 8 months, and when obviously, like you said, there is a progression. So when the parent is coming to us, maybe it's already midway.
Okay. So, I mean, what made smoking less popular? None of the guidelines did it. None of the do not smoke here did it. What really happened in terms of smoking was informal social controls. Changes. Let me follow that up. It's not as hopeless as the face you're making. What informal social controls means that you have universal intervention which targets everybody, that information goes out and people are aware. Because until you do that, yes, of course, you will handle the mothers in your clinic. You'll probably have, posters put up in the in your waiting space talking about what happens to the brain. And there's enough data, enough posters which show that. You will have posters about, the ones that I showed. That needs to be done. You also need to be able to get the pediatricians on board and start talking about it, because we are talking about a stage where none of us, reach. By the time they reach us, the horse has already fled from the stable.
True.
And which is why I talked about the universal intervention, which is required. Because if this message does not go out, if it does not go out in papers and TV, in movies, etc., it's not going to happen. It happened with smoking, which is why I brought in the smoking thing. Yes, it's a big thing to do. If you ask me, how does one reduce the burden of mental illnesses? I will say, let's go back to the sustainable developmental goals. You will make the same face, saying, when is society going to change? But ultimately, those are the things. Having playgrounds helps. Making buildings instead of playgrounds, worsens things. Getting children, playing on MMPORG games, does something to their brains. I'm sorry, I'll take just 1 minute, because the most depressing incident in my life, and I've had a few, was when I went to the Sundarbans for, with a friend who's running a floating clinic there. And the women came up there, the mothers came up and said, look, our men have left. They are in Bangalore or Hyderabad, because the land is poisoned. You can't grow anything there. The old men are drinking. Whoever the young fellows